All right, welcome from everywhere you have joined us from: Africa, Pakistan, Kenya, Ghana. Those are the countries, Egypt, those are the countries represented right now that I'm aware of. So if you are from any other country, just tell us in the chat where you're joining us from. We would like to acknowledge you and your country. So this is the Mentoring Research Network monthly webinar for the month of December 2024. And we are glad you're here. We have a special conversation set up for us, and we are looking forward to the lessons and the exciting conversations that are going to be held in this 1.5 hours. But I have a privilege. Oh, yes. So Aisha is joining us from the United Kingdom. Aisha, we acknowledge your presence. So I'm going to share briefly about the MRN. There we go. One short minute. And once I'm done, we would go into the conversations for the day. A brief minute. Okay. There we are. One brief. Good. So the Mentoring Research Network, well, it's a special team of researchers and early career researchers and established researchers. And the idea is to try to engage in transdisciplinary research for a better future. This is our website, the mentoringresearchnetwork.com. We invite you to visit the website. You can do that now or later. But for the next few minutes, I'm going to try to tell you what we are about. We are committed to international research, particularly from the Global South. The goal is to ensure that the voice of the Global South is represented in the research outputs in the world, especially because there's a lot of research coming from the Global North, but not enough from the Global South. So the goal is, particularly in Africa, we want to be able to contribute African research content from Africa by Africans for the world to use. Who are we? We are a network of vibrant grassroots initiative. We are spearheaded by dynamic researchers. Dr. Mona here is the executive director. And we've been operational since 2021. And we have a team of different scientists, scholars, early career researchers with different backgrounds and different institutions from across Africa. Our mission is to nurture research capacity and to facilitate knowledge exchange across vital domains, such as planetary health, environmental sustainability, climate change, traditional medicine, and indigenous knowledge systems. And we do these things on a monthly, at these meetings on a monthly basis. These are some of our past meetings. I will not go through all of them, but at least you can always go back and review them. And we make efforts to record each of our meetings and make them available on the website and on our YouTube channels for future review. This is our logo. Things that are available on our website. And when it comes to these are past videos of past events. And we become part of, join us, be a member. Membership is usually open twice in a year. It's a 6-month cycle in January and in August. Uptake in January of 2025. And we would, I'm sure before the meeting ends, we'll share the links to how to become a member in the chat, and to contribute to our goal to make research in Africa have a voice from Africa. Share a few were
Thank you so much, Percival, for this wonderful introduction. So let me take it from there and introduce myself. My name is Dr. Mona Esherbini, Associate Professor of Infectious Diseases, particularly in parasitic infectious diseases at Cairo University, Egypt. And together with Samuel Abimbola, he is a public health researcher at Cyprus International Institute. Together, we co-founded the MRN, and since 2021, we have a very nice cohort of scholars where we are trying to meet every month and also make research publications. So regarding the topic of today, let me say briefly some of the statistics, and Percival will then mention the objectives of this webinar, but let me just start with some facts, because we always know that Africa has been suffering from a lot of infectious diseases, particularly malaria, some of the viral vector-borne diseases, and so on. But recently, we are witnessing like key statistics revealing alarming a number of mortalities and morbidities due to non-communicable diseases. So regarding the WHO African region reports, they mentioned that NCDs or non-communicable diseases account for 37% of deaths in 2019 and up to 24% in the year 2000. Nevertheless, we also have some of the statistics regarding specifically cardiovascular diseases, which is the most common cause of non-communicable diseases related health. And it's responsible for 13% of all deaths and 37% of non-communicable disease deaths in the whole African continent. Regarding the statistics of cancer, in 2020, Africa reported around 1.1 million new cases of cancer and 700,000 cancer-related deaths. And although the continent accounts for 5.7% of the global cancer incidence, it bears this disproportionate share of cancer deaths at over 7%. And then when we see the projections of cancer death rates in the whole African continent, we will find that it almost exceeds the global average by 30% in the next 2 decades. Hypertension is also in the list, and then I want just to take it forward to 2030. The future projections estimate that sub-Saharan Africa, the prevalence of non-communicable diseases would even surpass communicable and maternal, prenatal, and nutritional diseases, mortalities even. So this prevalence is also high in youth, and this is almost like very alarming that younger diseases of younger non-communicable diseases are also seen in the second or third decade of life in sub-Saharan Africa. So with this, I would like to say that focusing on prevention, early detection, effective management is so important. But then when it comes to nutrition, this is the core of how we can manipulate and adjust this imbalance in the prevalence of non-communicable diseases. By non-communicable diseases, I mean cancer, diabetes, hypertension, cardiovascular diseases, and obesity. So with this, I would like also to take it from there and introduce our moderator, Percival. So let me introduce him. Okay, just bear with me a second. Okay, so Percival, do you have any comments regarding this kind of alarming statistics from the WHO?
I certainly do. I guess anytime I read WHO statistics, the first thing that comes to mind, Africa is always the worst hit. And how that is the case is always amazing. But the fact that I mean, non-communicable diseases are on the rise, and they go undetected in many African communities and many African countries, and that is a real problem. And that's where nutrition is like the foundation of many of the issues that has got to do with non-communicable diseases, because most of them are nutrition-related or diet-related diseases. And so I think that there couldn't have been a better conversation today, because carbohydrates, forms about 50 to 60% of the meal. And so that makes this conversation very relevant. And I think that we will want to have this discussion and have it and contribute to it fully. Over to you, Mona.
And thank you so much, Percival. And I'm so excited to hear from both Dr. Alice with all her experiences, and also from you trying to do the synthesis between East African approach and for yourself, West African approach in Ghana. So with this, I would like to introduce you Percival Agordoh is a lecturer at the Department of Nutrition and Dietetics at the University of Health and Allied Science in Ghana. He is a registered dietitian, nutritionist with a deep passion for research in indigenous foods and food systems nutrition in infectious diseases like malaria and HIV, food environment research, and implementing science while also implementing research in non-communicable diseases. His growing interest in planetary health and climate research focus on how these factors influence the nutrition and well-being of marginalized, vulnerable, and traditional communities. Percival was the chair of the local organizing committee for the recently concluded 9th Africa Nutrition Conference held in Cape Coast in Ghana. In addition to his academic pursuits, he is the immediate past vice president of the Ghana Academy of Nutrition and Dietetics and a former president of the Ghana Dietetics Association. Percival holds a master's degree in dietetics and a PhD in public health. He is also pursuing a second PhD in dietetics at the University of Ghana. So it's truly an honor to introduce you, Percival, and you've been joining the MRN community for quite a long time, 2 years almost. So with this, I will give you the floor so that you can also introduce Dr. Al.
Thank you so much, Dr. Mona. I just lost words on how to express my gratitude. Sometimes when I hear my profile read, I am not too sure if I'm the one, but I'm glad that I'm able to connect with that. But team, you are welcome to this meeting. I'm happy to moderate this event, but I'm even happier to introduce to you Dr. Alice Ojwang. And Dr. Alice Ojwang is a nutritionist, a dietitian with significant experience, over 20 years of experience, working in management, prevention, and control of obesity and related risk factors. She holds a PhD in science with dietetics from the Northwest University in South Africa, and she has been instrumental in shaping the dietetics profession in Kenya. Dr. Alice Ojwang is very passionate about dietary intake and health. And she with a doctorate degree in dietetics, her research interests or areas of interest and health promotion include focus on dietary intake in management, prevention, and control of obesity, hypertension, high cholesterol, and type 2 diabetes. Now, she is the academic team lead at the Department of Human Nutrition and Dietetics at the Technical University of Kenya in Nairobi. And in addition to that, she's a lecturer, practitioner, researcher, and mentor. Currently, she uses digital platforms to impact the health of large populations in Kenya and across Africa. She's a sports fanatic and has a healthy, active lifestyle full of interesting hobbies and more. And the one thing that endears Dr. Alice Ojwang to me is her favorite quote, which I think resonates with all nutritionists and dietitians globally. And it says, and I quote, taking drugs without eating healthy is like washing hands and drying them in the dirt, unquote. I'll repeat that. Taking drugs without eating healthy is like washing hands and drying them in the dirt. It's an anonymous quote, but friends and audience, I want to introduce Dr. Alice Ojwang, our speaker for today. And she is going to be speaking to us on carbohydrate intelligence in an era of rising NCDs, a planetary health perspective. There are quite a number of objectives, but key among them is to analyze the role of carbohydrates in the development of non-communicable diseases, particularly in diabetes, obesity, and cardiovascular disorders, and to discuss how carbohydrate consumptions interact with the planetary food systems and sustainability. And among that, to also engage with us, health workers and policymakers and educators in actionable discussions on how we can sustainably find solutions with a planetary health mindset to improve carbohydrate intelligence and carbohydrate intake among our people. So without much ado, I will just welcome Dr. Alice Ojwang to take over and share with us her insights. Over to you, Dr. Alice.
Thank you so much, Percival, for your very nice introduction. Thank you, everybody, for being here. And so I'm going to talk about carbohydrate intelligence, but I'm looking at it from the approach of how I actually, what do I tell my clients? What do I tell people? And why this is so important to me, because I found that, things like reversing type 2 diabetes is very easy. Reducing what the patient, the medications the patient takes from all these chronic conditions is very, very easy by just learning carbohydrate intelligence, So I'll share my slides and then we can take it from there. And yeah. Okay, you started with my favorite quote, which is taking drugs without eating properly is like washing your hands and drying them in the dirt. And it's actually a 1995 quote where this was in this conference, a HIV conference in Zambia. And this doctor went ahead and said how everything ARVs, and it was the era of ARVs and how that was very, very good for patients. And then somebody actually asked him, you mean nutrition doesn't play a role? And this was his quote, yeah. So it does play a role. So if a patient does not eat properly, medication is not going to work. And as Africans as nutritionists across the world, across Africa, this is what we need to sing for our patients, because the approach here in East Africa, or let's just talk about Kenya, this is where I know most, we just pump patients with medications. It's medications, medications, medications. The patient is going through a lifestyle changing. Even the doctor still doesn't change medication, just say, do it, So it's not fair. So we have to take the lead in educating patients. So what's carbohydrate intelligence? It's really just looking at carbohydrate in a different way. This is what I've been telling people with diabetes for a long time, but now this is what I tell all my clients when they come to see me. Currently, I work with groups. I do a group wellness program rather than individuals. I've been doing that for 25 years, and the last 5 years I decided, no, if I'm going to impact more people, then I need to do group. So I have group wellness. And yeah, so what's carbohydrate intelligence, which is really learning how to count carbohydrates. It's a meal planning approach, highlighting on the total amount of carbohydrates consumed. The source does not matter initially. The type of carbohydrate consumed does not matter, because a carbohydrate is a carbohydrate. For example, when you take carbohydrate, it becomes 100% sugar. It becomes 100% sugar. And so it doesn't matter what carbohydrate you take. You take whole wholemeal comes 100% sugar. You take refined, it becomes 100% sugar. And so if you're dealing with people and you tell them, oh, wholemeal is better, that gives room for fraud, because we know a lot of people, nutrition fraud, where they will tell, oh, this is a diabetic bread and this is diabetic this. And the minute people are going to take that, then they can take more. But because it's still a carbohydrate, it matters. So why is it important to control blood sugar, control weight, prevent chronic diseases, and improve quality of life? And it's unbelievable, but when we eat less carbohydrates in our diet, it actually makes a huge difference, as you're going to come and see. So which foods do we classify as carbohydrates? Some two people in this group has listened to me, but for those who have not listened, what foods do you classify as carbohydrates? Just as a way of knowing, can you just type it in the chat? And then Percival, you read for me. What foods do you classify as carbohydrates? Is there any in the chat?
Not yet. There is wheat.
Wheat.
Rice.
Yeah.
Starch and sugars.
Okay.
Starches and sugars.
But we can see mostly all those things that have been classified there as starches, all right? Starches, right? Okay,
Yes.
It's true. All starches are carbohydrates. There's no doubt about that. But also, all fruits are carbohydrates. Remember, fructose? All legumes are carbohydrates because they are mostly 60% carbohydrates and then other nutrients. All types of dairy except cheese are carbohydrates. Okay, lactose, right? Yeah, I can see you making a face. All sweetened beverages are carbohydrates. We know that, okay? So of course you remember this. Rice and breads and rice. Legumes fall in this category. And when I say legumes, most of the time when we have patients we fight and they go onto the net to check, and you find that most of the legumes actually are my 60% carbohydrates. And so they qualify to be classified there. Of course, pasta, dairy, we've said, fruits and juices, and of course, smoothies, fruit and sugar-based smoothies. Otherwise, if it is vegetable-based smoothies, those are fine, you know. So why are they all classified as carbohydrates? Because glucose, your starches are broken into glucose, your milk is broken into lactose, which is made of glucose and fructose, and then your fruit is made into fructose. So they're all carbohydrates. And so over the years, we find that people just eat these things together. And this is because there's been dietary confusion. First of all, people are told low fat is good. But when you look at it, low fat, if somebody looks at the calorie intake, they find that low fat actually is high in calorie. So what will they do? Oh, that's so they avoid the fat because it's high in calorie and eat more carbohydrates and protein. But because protein is expensive, so it's easier to eat more carbohydrates. And so what will be the problem? And also the other confusion is growing up and actually having done undergraduate also in nutrition, this is what you're told to. Prescribe 60% carbohydrates in people's diet. And so people consume a lot of carbohydrates. Yes, there's an age group that it doesn't matter when you're younger, you know, but there's an age group that it does matter. So this is just a reminder. But what we want to remember is diabetes is a condition that affects the way your body uses food for energy. So you just remove the word diabetes. Whenever you take carbohydrates, the body uses it for energy. Any food we take, the body uses it for energy. So diabetes is just a state where the body cannot utilize that energy, you know. So that means all of us need to pay attention. Are you eating carbohydrates? Because as long as we drive our sugars high from eating too much carbohydrate, eventually we become either insulin resistant and we end up with diabetes. So this is also a reminder, nutrients and the impact on blood sugar. Anytime you take a carbohydrates, it raises your sugar more and it becomes 100% sugar. Your protein becomes about 60% sugar and fat is about 10% glucose. Okay, when I say glucose, Sugar, it means glucose, but I should actually use the word glucose. Okay, sorry. Excuse me. By the way, I have COVID. So, this shows, so the more carbohydrates you take, the higher the blood sugar. The more carbohydrates you take, the higher the dosages of medication you take. The more refined of it, the higher the dosage of cholesterol and especially diabetes. And the more carbohydrates you take, the easier it is to gain weight, and the more your weight is going to go, and you're not going to prevent it unless you change. Whatever you do, if you don't change the amount of carbohydrates you take, it's going to be a problem. And also, when you tell people this, then they go on a high protein diet. It doesn't matter. When you eat protein only without carbohydrates, then what happens to the protein? The body converts that into more sugar because the body's main energy is glucose. So the protein will be converted into higher amounts of glucose. So we just need to eat a balanced diet, in other words, okay? So defining carbohydrate. So high carbohydrate will be defined at over 225 grams, which is high. Medium is 130. Low is, 50 to 130. And very low is 20 to 50. However, people have to learn this. And this is what I help some of my patients to see. And why is it important? Because David Unwin, who is a UK endocrinologist, did a study that found that when you consume 5 grams of carbohydrates, it's actually equivalent to consuming a teaspoon of sugar. So when they, and he did a study where the more grams of carbohydrate you take, the higher your sugar rose. So if you take like 10 grams of carbohydrates, like taking 2 teaspoons of sugar. So it literally shows that this is the impact on your blood sugar. Eating 5 grams of gram, it's like taking a teaspoon of sugar. And so that's the impact it has on your blood sugar. So the more carbs you take, the more sugar you take. And you'll see this from some of the meals I'm going to present here. So this is some of the examples, some of his infographics, which is freely on his website. I'll share that shortly. So on a normal day, East Africa, I say, UK, many countries, you take cereal, toast, and fruit juice for breakfast. That is considered a healthy meal. But you can see cornflakes will give you about 8.30 grams of cornflakes is equivalent to taking 8.4, okay, teaspoons of sugar, meaning divide 30, okay? And because it's refined, it has more sugar. Milk will give you at least 1 teaspoon of sugar for 125 ml. Brown toast, one brown toast will give you about 3 teaspoons of sugar because it has 30 grams of carbohydrates, 15 grams of carbohydrates, let's say. And pure apple juice will be 8.6. So it means when you take a healthy breakfast, which most people consider, that is 21 teaspoons of sugar. So if you're at this age group, 30, 40, 50, soon enough, you're going to have a problem, sugar intolerance or glucose intolerance. And we can see, these are many cereals that are found in our supermarket. And you can see the more refined they are, the higher the blood sugar content, which is actually equivalent to the glycemic index. The higher the glycemic index, the higher the amount of sugar. And you can see also when it comes to rice, okay? Rice, potatoes, very high in sugar, French fries, spaghetti, white, okay? So banana, about 6 teaspoons of sugar. Apple is better, okay? Wholemeal, small slice of bread is much better. Broccoli, 0. And so the story goes on. This is just for fruits. So if you take all these fruits, you can see a banana will give you a higher blood sugar content than strawberries. So it means it has more carbohydrates. And so then sometimes if the client, whatever is available to them, they need to choose. But you eat what's available to you. You must just know how much carbohydrates do I need to eat in a day. And of course, the list goes on. So what happens? We made a book. This book, we measured carbohydrates and the amount of carbohydrates and the amount of sugar it has there. So this is like 150 grams of rice, which has about 42 grams of carbohydrates, which is equivalent to 9.2 teaspoons of sugar. So we divided the carbohydrate. A teaspoon of sugar, people say it's 4 grams, 4.25 or 5. So we used, I think we used 4.5 to be able to get that. So you can see bread, 1 slice of bread, white bread is 4, brown bread is 3. So of course, brown bread is better because you have less glucose or less carbohydrates in it, okay? But the more you eat, the higher the glucose content. And this is what we call chapati. Very common in East Africa and something that's originated from the Indian, and people like it. And the more you take it, you can see what we get from there. Potatoes and beans, you can see beans, it's carbohydrates, okay? And of course, we have also, the book has got mixed foods, commonly consumed. So we looked at some plates for clients. So people send their plates in the program, and so we are able to tell them the mistake that they're making. You can see this client has maize and beans. That is already 2 carbohydrates. Then they eat this meal, and they eat this meal with the fruit. So they're taking double carbohydrates, and that is going to increase their blood sugars will be a lot higher than if they just ate this and maybe increase the vegetable. And this is double, you see, still maize and beans. But this is worse. They have rice, and then they have fruit, okay? Double carbohydrates. And so all these are double. They have potatoes and they have beans. They have rice, they have beans. They have fruit, and they have chapati. They have, this one has, yeah, also double carbohydrates. You know, this is beans and this is chapati. But then they have protein. And of course, this is also just a large portion of food, okay? And we have, this is just a lot of fruit for somebody who, you can't just eat so much fruit in a meal, all right? And so the education we give the patients is they need to have 1 carbohydrate a day, and we'll come there. So you see, this is somebody having 1 meal. So they have, this is beans, and then they're going to eat some bread, you know, okay? Yeah, this is some fruit here. And, you know, you get the drill. This is rice, and this is chapati, and this is also rice, and this is beans, and this is chapati, okay? This is just fruits, and you take off. Sweet potatoes with beans and potatoes. And this is a very common, this is what people do. There's always beans, there's always, you know, bread, beans, always beans. Beans is a major meal, but you see, people don't eat a lot of vegetables. So anyway, when we calculate the amount of sugar they take, you can see this is rice with chicken, potatoes, rice, and they have almost 22 teaspoons of sugar equivalent. Yes, you need to have amount of carbohydrate, but how much? So this is too much for 1 meal, because that's about what you need to have in a day. And you can see this person has 3 triple carbohydrates. They have a yogurt, they have fruit, and they have bread. Not too much sugar, but however, this is a meal that you're going to utilize it very quickly, and then you'll be needing something shortly. Because what it also does, it increases your insulin response index. So you eat it, the insulin levels are high, brings it down. 2-3 hours later, you need another meal. So not good, all right? This is somebody who makes 6 bananas and oats. So they make a smoothie, you know, 6 bananas, okay? We even looked at the smallest banana. Of course, she didn't use the small one. So 3 teaspoons of sugar, okay? Times 6, almost equivalent in just a cup. I mean, there's no way ever going to control the weight if you eat like that, or even control your blood pressure. I mean, your blood sugar. You can eat all these things, but how much and how often? This is somebody who was telling me they're given in hospital. So they're given fruit, they're given yogurt, pancake, and they're given yogurt, and they're diabetic. Triple carbohydrates. Look at that. Okay, this is just a lot of carbohydrates, you know. Okay, we talked about what? There's a repetition. Yeah, you can look at that. Have a fruit and a whole load of you can see. This is a whole load of oats and a fruit, you know. Yes. White bread and more. So anyway, what am I saying here? You get the drill. People take too much carbohydrates, and if you're going to help, then we have got to manage. So here is a case study of somebody, we studied their food. So we studied their food. So what you do, you send your food pictures, and then we say double carbohydrates, please use 1 carbohydrate, replace that section with vegetables or increase your protein. And so we had this patient for just 6 weeks. And you can see when he came, his cholesterol was very high, okay? But let me show you different graphs. So here is his HbA1c, 11.86, all right? But I think this is better. So when he came, his average blood sugar was 16.3, which is very high. But after just 6 weeks, we have 6.17, which is dropped. HbA1c was 11. By the time we finished, 5.56, right? And then his cholesterol was at 8.3. By the time we finished, it was 4. And triglycerides also dropped. All right. And HDL also, HDL was not too bad, but it dropped. But you can see LDL, terrible cholesterol, dropped significantly. All right. So, of course, he was 80. I didn't put the original weight. He was 86 kilograms. He lost up to that. And we didn't put him on a weight loss. Just cut down your carbohydrates and show him how, you know. And so that was about 15 kilos. He lost pretty fast anyway, because he used to eat really badly, all right? And then we have case study 2. This is a female who, by the time we finished the program, this was 12 weeks, you can see she was taking about 11 drugs, okay? And by the time we're done, she was taking 4 medication, but I can tell you now she's on 2, all right? So that is very, very significant reduction in medication, you know, okay? And here, see, she saw her medical doctor. The doctor was happy. She was weighing 97. In the record now, he was 86. That means 11 kilo. Very happy and told to continue with whatever she was doing, you know. Yeah. So in short. And of course, we have many case studies. We have done and looked at the patient's medication, the medication the patients were consuming before we put them on a or took them through the carbohydrate intelligence program. And so after that, we did the mathematics and were able to share with the insurance company to show that if the patient just went through 2, you know, like there are literally 3 sessions, your portion size, carbohydrate intelligence, and exercise, you know, just 3 sessions, they're able to reduce their medication. 80% of the participants reduced their medications. 80% lost weight, okay? And so they would have a lot of savings if they invested in this. So anyway, yes, so genes load the gun, but the lifestyle is the one that pulls the trigger. So the call to action for all nutritionists, for all health professionals, is really to teach the clients to drop the carbohydrates. This is definitely going to help the clients to stop taking medication. This is going to help people to eat more natural, plant-based, eat a lot more vegetables instead of the meats and all those refined carbohydrates, which will definitely help our lives and also help the earth. Thank you very much.
Thank you, thank you, thank you. That was a very exciting presentation. I can see the comments in the chat. It says, "Bravo, Dr. Alice, that's an efficient dietary program." Then the other ones are, I'm sure, lamentations after they saw your slides on cutting down on carbohydrate portions. So
yeah.
For example, even my lovely banana. Oh, my banana. Banana is not something I can eat, I guess. So this one is written in typical Ghanaian slang. Charlie, Wahala don't be like this.
What does that mean?
So Charlie is like, it's like the Ghanaian way of saying my guy or my friend. I mean, so everybody here in Ghana is Charlie. And then so you don't need to know somebody's name. All you need to just say is Charlie, and then you start speaking. Then, but the rest of it is Nigerian pidgin, generally. Okay, so that has been a thrilling conversation. I don't see any questions in the chat. I don't know if anybody has a burning question. Otherwise,
But I can say something as they wait for the question. So now what do we actually tell clients? So you have to think about what carbohydrate you're consuming, either for breakfast, for lunch, or dinner. So you see, you don't eat a meal and then you eat fruit. That fruit has to be part of a meal. It cannot be a snack on its own. So if your breakfast, which should be the heaviest meal, the breakfast should have your piece of meat, vegetables, and a banana, and beans, and bread. So your carbohydrates becomes part of your meal and not part of snacks. And in one meal, you choose to have one carbohydrate and not 2 or 3 as the norm. Yeah. Then we can say your carbohydrate intelligence is high. And when we do the session, people never talk to me. They all get so angry. But shortly after that, when you look at their plates, it's changed, completely. Yeah.
I can relate to that. So I see that the essence of the program is more of a low carbohydrate diet rather than
no. It's not a low carbohydrate diet. It's having one, but it's reduced carbohydrate, because if somebody was going to have rice and beans on their plate as part of their meal, and now they have to remove one and just eat one carbohydrate, okay? So it's not a low carbohydrate diet, it's a carbohydrate intelligence diet.
That will bring up a lot of cultural issues in Ghana, because there's a favorite meal in Ghana which is made with rice and beans. We call
yes,
it wache.
I know. And by the way, I've had Ghana. The first trial for the carbohydrate intelligence was actually a group, West Africans living in the UK. Of course, at the beginning of the program, we really had a few fights, but they actually learned to include vegetables, because most of Ghanaians don't have vegetables in their diet. Vegetable is has as a small portion. And so as long as the clients see that their sugars are getting better and the dosages of medication are reducing, then they actually go for it. But because it's in nature, and most of our African meals from South Africa to North Africa, it's very high in carbohydrates. And so that's why all these multi-million pharmaceutical companies are making money from us, because patients are taking so much medication, so much, and they don't need to, yeah.
Yeah, I get that. Someone is singing my song in the chat. Wachi is in trouble. But Samuel, you do have some questions. Let me allow at least one question, and then I'll have a few slides I would share, and then we can have the discussion thereafter. Samuel,
thank you very much. Thank you very much, Percival, and good evening, Dr. Alice.
Good evening.
I think my questions are everywhere in my head, and I'll just try to just ask one, and it's about this carbohydrate intelligence. I looked at the list of food that Dr. Alice presented, and how these foods, to some extent, perhaps culturally, have been misclassified as protein, whereas they are carbohydrates. And the one that's shocking to me is fruits. We've always considered fruits to be an exclusive or a separate class of food on its own. We put as vitamins, fruits and vitamins, and we almost categorize fruits and vegetables together as source of nutrients or food substances that are very nutritious. And I just want to ask, with this carbohydrate intelligence, is it also important to mention that it has to be personalized, in the sense that I'm looking at my meal from birth till date, and I think I would say if I begin to mention what I eat, you would almost recommend me for emergency therapy, because I go on bread for as much as I sometimes eat bread twice a day for 5 days straight in a week, because it's the fastest thing I can lay my hands on when I'm very busy at the lab and I cannot go out, and I don't have time to cook. And I've been doing this for years, especially even when I have exams. I just eat pasta for breakfast. I have rice for dinner. Of course, I would say, okay, I have beef or meat or chicken with it. But the ratio of rice to beef or the portion of rice compared to the chicken is as far as day to night. So I'm kind of shocked that I've lived supposedly healthily till date. And my question is, could it be that individual metabolism might differ so much so that we do not see the effects of this high carbohydrate diet we've lived on for so long? Quite evidently. And in Africa, sometimes when you bring these kind of conversations to the table, you have people who tell you, my forefathers ate this. My grandparents survived on this kind of meal, and they lived up to 80 years, up to 90 years without any known health complication. So how do we balance traditional knowledge, just like Percival also mentioned, some of the things that we've had in our society for long periods, or for as long as we've been? How do we balance this carbohydrate intelligence with cultural norms that might actually not be very carbohydrate wise in the African context?
Okay. Thank you very much. Sam, you've asked a lot of questions. I'll try to answer briefly. So one, you says whenever we group foods, we group as vegetables, nutrients, there are different groupings of food. And if you want to group foods like in 3 categories, you group them as carbohydrates, and then you group them as proteins, and then you group as fat, Then you have your vitamins and minerals, goes there. However, we just know this, we've never thought about it. Your fruit has got fructose, and actually fructose is the worst sugar. It's the worst sugar. I remember being in a conference in 2010, and one of the things they said is that fructose is going to be the next tobacco because people are abusing fruit. You can eat, if you're given a whole fruit, you can't eat like 5 fruits in one sitting. But if you make juice, you will drink 5 fruits in a glass. And that's a lot of fructose, which actually cause problems. So that's question one. So people this has always been known, but it's not been educated to people clearly, because we've known like fructose is the worst sugar, and we have glucose and we have lactose, even though lactose is very little, it's not too much. It doesn't affect your blood sugar much. But when it comes to, excuse me, like you said, you've been consuming a lot of this and everything is okay, but it's age group. Is age group, okay? You can get away with this when you're young to about 30. You can get away with it. But after that, it starts to impact your weight and it starts to impact your life. But one thing is also for sure, depending on which parts of the world you live in, people also eat very whole and natural foods. And this you can get away with. But in some parts, right now, people eat a lot of refined carbohydrates. And that's a problem. Things like beans, beans is got a protein quantity, but for a long time it's classified as protein, even milk. But it's not. It's actually, look up beans, look up the nutrient content of beans. Several beans is going to have about 60 or 70% carbohydrates. And then the rest is, there's protein, and then there's other minerals, yeah? But what we do is, we actually personalize. So we look at your plate. So you have to send your food picture. What do you eat? All right. So if somebody eats a lot of double carbohydrates, you encourage them to remove one and replace that section with vegetables. So you're actually also encouraging intake of vegetables. So you really personalize it. Of course, when you go through the sessions, usually people are like shocked, and then there are many arguments. But you see now, unfortunately, most of the time, the dietitians, I don't know about you guys in other countries, but we receive patients when they're already sick. They're already very diabetic, very hypertensive, very overweight, and they need this to go. So eventually they have to listen. But we also know in many countries in Africa, complications with diabetes is so much, amputations, blindness, and these are things that are preventable. And this is why most of my heart goes out to people living with diabetes. So I'm trying to do this to get them early. because there's evidence. We're building a database, we're building an evidence base. They go through the program, you know, they actually are able to reduce up to, you saw that patient, up to 9 medications off the diet, off her treatment plan because of carbohydrates. So it is talking to people, you can't push them, but when you educate people and educate them properly, then they make the changes that is going to benefit them. Yeah. I hope that answers some of your many questions.
Wonderful. Well, I believe in that.
Thank you very much.
Yes.
But you're still here.
Okay, so I'm trying to share my screen. I don't know if it's
we could see it.
Great. So what I'm going to try to do in the next few minutes is to situate this conversation in the planetary health perspective. So I see that what Dr. Alice spoke about is more of the individual level conversation. So most of these discussions from Dr. Alice is looking at the individual. And we tend to look at health like that when you are looking at the curative, if you like, the curative arm of healthcare delivery. But now the thinking is that our individual actions affects the whole public, that affects the world, and actually affects our planet. So it's a whole, we want to look at health, we want to have carbohydrates, even its effect on us, it affects all of us, and affects even the animals and the oceans and the living things therein. So putting this in that context may help us appreciate the discussions we're having. And when it comes to planetary health, the core principles are interconnectedness, that what we do is connected to one thing or the other. So if you eat 1 carbohydrate or 2 carbohydrates or 3 carbohydrates, it means that you are reducing, most likely, or increasing the amount of carbohydrate taken, and that can affect the amount of protein that you may consume, and that will actually affect the amount of animals sorry, that may have to give up their lives to provide the protein, and that can affect the amount of water that will be used to produce that 1 or 2, 3 carbohydrate portions that you are taking, and that can affect a lot of other things. And they're also looking in the time when the world is gradually going to the brink of extinction. The statistics suggest that we're able to produce enough food to feed all 7 billion people, but we waste a third of it each year. So a third of the foods that we produce do not get eaten, they are actually wasted. So we are looking at how to make these foods available throughout time so that everybody can have access to them. And then that brings up the conversation of equity and justice and all that. But typically when the planetary health ideas are discussed, we're looking at climate change. Those are the ones that people tend to focus on, biodiversity, built environments, and things like that. But in this context, we're looking at, I'm just going to show you that the planetary health framework actually highlights malnutrition as a key factor, and also highlights non-communicable diseases as one of the things that is driving the health outcomes that we should be, health effects of a poor planetary management, and that involves, again, from today's conversation, the way we treat and handle the production, the consumption, and the distribution of carbohydrates. And so that, again, goes directly back to our food production system and our biodiversity, or how carbohydrate options are available to persons who are even able to acquire them and to consume them. So there are people who do not even get it at all. And again, we had a discussion around culture and behaviors. So if we are used to a culture like in Ghana, where wache is taken together, rice and beans taken together, concepts like a 1 carbohydrate diet or 2 a double carbohydrate or triple carbohydrate may have to be contextualized, and we need to look into all of that as well. But the significance of carbohydrates in diet is being established clearly, and I think Dr. Alice managed to highlight that carbohydrates is a primary source of energy for the body. It affects our brain function. It is very important in the digestion of nutrients, particularly fiber, for example. affects the absorption of glucose into the bloodstreams. Then carbohydrates, the presence of carbohydrates, we call it protein spares protein and makes protein available for other uses or other functions in the body. But then you see carbohydrate becomes important in physical activity or physical performance. So particularly in persons who are athletes or sports people, if you are going to be physically active, you need energy, and that energy must come from a food nutrient, and most of it usually is from carbohydrates. And of course, carbohydrates, having enough carbohydrates or adequate carbohydrates on your plate will ensure that you are satisfied after you've eaten. I think that usually is the bottom line when people are looking at their diets. Am I satisfied after eating a meal? And that is where I think that Dr. Alice may want to explain to us if the people on the program actually get satiety. Now, but the impact of carbohydrate on the planet is enormous. In producing these foods, the greenhouse gas emissions are significant. And usually for rice, wheat, corn, the contribution to greenhouse gas emission is one of the highest, because these are the ones that are usually used to feed the animals, usually the cattle that produces the milk that we will use in the food value chain. And then in producing these foods, water usage, what you call the water footprint, for example, you need over 2,500 liters of water to produce one kilogram of rice. And that's the highest water usage. So you eat rice, yes, it is we recommend it as professional dietitians to people, but in thinking of eating rice, the effect of that 1 kg of rice on water scarcity or water usage on the planetary level is also something that we need to consider. And then the land use, of course, all the foods we will eat, all the carbohydrate sources that we can think of, whether they are starches or fruits or even simple sugars, the source will have to be from some form of cultivation, and that would involve the use of land, and that may mean creating a farm and farming them, and that can have significant impact on deforestation and biodiversity. And you see, monocultural practices along the line have come to the point where agroecological practices where the industrial thinking has made it almost difficult or almost impossible to find plants or food crops grown along with other crops. Usually they are grown as monocrops. So if it's rice, it's a whole field or plantation or as well of rice. If it is maize or corn, it's about the same thing. But the evidence suggests that monocropping actually does not improve on the quality of the rice, because then it affects the quality of the soil and the nutrients in the soil. And so then the rice or the foods or crops that are grown in monocrops are not advantageous in the long term. And each food carbohydrate option meal that is produced, I think I left something out here, affects the consumption of water, of energy, and transporting it from the farms to the markets or to the homes. All that is a sort of energy consumption. And again, food loss, post-harvest losses is also another component of food waste, which is something that affects the supply chain. And all of it affects how much food is even available for each of us to portion on our plates to now follow a healthy diet plan. So when we're thinking of carbohydrates, we also need to expand our perspective beyond just the plates that we are eating. Now, these are just suggestions on how to make these sustainable. There is currently a strong emphasis on plant-based diets, promotion of plant-based diets. The Lancet Commission has a full paper on plant-based diets. I would like to know what Dr. Alice's suggestions are on that going forward. Then there are also conversations around alternative carbohydrate sources like seaweeds, mushrooms, and then ancient grains and others, which are been suggested to have some environmental benefits. Then there's other things to use other forms of of agricultural practices to regenerate the soil so that we will have a sustainable way of ensuring that we have enough foods grown. Then there's also a lot of research now, particularly from Netherlands, on vertical farming, or food system innovations, where you can basically farm along high skyscraper buildings or high-rise buildings rather than on the ground, because then we've learned how to build technology upwards. So you live on several floors up, and they are thinking of their ways of. There are actually agricultural practices that are thinking of growing food in they call them something gardens. Like the word just escaped me, but otherwise window gardens. So you grow foods just on the in your porch or your window on high-rise buildings and all that, and that is all ways to improve the availability of carbohydrates for the purpose of preserving the planet. Now, but there are a few things that we must consider when we consider carbohydrates in the general sense. So, for example, there are policy issues and there are behavior changes that must come to play to achieve a sustainable production of healthy and nutrient-dense carbohydrates. Now, that nutrient-dense is a very complicated concept, but for a carbohydrate to be nutrient-dense means it has enough carbohydrates in it. And I'm sure that typically a serving of carbohydrates is generally considered around 15 grams of bioavailable carbohydrates, and that is what we would typically recommend. So if we are doing that, we want to ensure that in every portion of meals on the plate, you should be able to get a good portion of high quality carbohydrates from good sources, which are devoid of pesticides and other contaminants. And that will mean that there should be a strong emphasis on consumer education and behavior change. And I think that is what Dr. Alice's work is highlighting strongly. And then there are discussions around food labeling and food certification, because then if a food product says on a package low carbohydrate or good source of fiber, I mean, we should know that it contains exactly what it does contain. And then of course, the rest are policy conversations. Now, I just put this slide to highlight that the conversation on carbohydrates is not just to us. It actually finds its place in a lot of the sustainable development goals. And all of these ones have got to do directly or indirectly with protecting the health of individuals. And then here we are looking at non-communicable disease, which reduces the productivity of the workforce. And so once that is affected, we want to ensure that we are able to provide the right amount of carbohydrates, the right amount to manage the non-communicable disease burden, so that people can be able to live a healthy and safe life too, and to contribute to the development of the world generally. So here I'm seeking to discuss synergies. So as Dr. Alice was presented, I was just reflecting on two things. So here in Ghana, in West Africa, generally, and particularly in Ghana, we would look at carbohydrates in terms of the proportion of contribution to the acceptable macronutrient distribution range per day. And so rather than look at the carbohydrate on the plate as in one carbohydrate option, two carbohydrate options, or you call them single, double carbohydrates, triple carbohydrates. We in Ghana typically will look at the contribution of all carbohydrates to the nutrient requirements per day. So, for example, if we determine that a particular individual, these are the individual level, requires 60% of their nutrient intakes to come from carbohydrates, we will take that and translate that into how many servings of carbohydrate that will translate to. And what we do typically is to subtract the carbohydrate contribution of each individual foods, including milk, legumes, and other carbohydrate-laden foods. So breads, cereals. So we take them out, and then we take. So for example, 60% of 1,600 calories of energy coming contribution to the person's requirement for a day, assuming that it's a 1,000 calorie diet. So in that 600 calories, 600 of calories will translate to divided by around 4 calories. That translates to grams. So we take all the carbohydrate contributions from other foods like milk and other things out, and what is left, we convert that into the amount of carbohydrate servings that can be added to a diet. Now, our philosophy is dietary diversity, because then we are thinking that having a one carbohydrate serving on a plate, now is not a typical thing that the West African culture does. Yes, they will do a corn meal. In Nigeria, for example, they will probably have a eba and egusi soup. But you see, egusi is a vegetable, which in essence is also a carbohydrate. And so if you took eba, which is essentially cassava, it's a starch, and then you added that to egusi or to any other vegetable soup, you would want to ensure that the person is having that diversity. So, and then adding that to other food options, fats and proteins and all that. And so typically dietary diversity is about 4 to 5 different food options, minimum 4. So we emphasize on a variety of views, including fruits and vegetables. So yes, in principle, we do agree that taking a fruit together with a meal is maybe an overkill, but then you want to still in that meal preserve the cultural practice of people, of persons, and then ensure that they have close to that. So they are still eating in principle within the recommended proportion of energy assigned to carbohydrates within the day. But then the other things that I think that both East Africa and West Africans do typically, for what you presented, Dr. Alice, is that there's a emphasis on using local and seasonal foods, which I think is very critical to ensure the sustainability of our approaches going forward. Then, of course, traditional diets, that becomes the conversation. I think I highlighted that the cultural acceptance of foods, it borders around the traditional diet. So, and I think it was someone who asked the question and mentioned that we want to, people who say, this is how my forefathers have eaten this for several years on end, and they would want to ask, why should it be different? So in preserving the culture and the tradition in diets, I think that those are some places of synergy we can discuss going forward. And again, I think I'll leave the rest for later. But overall, we are looking at encouraging healthy diets and ensuring that these healthy diets are sensitive to the non-communicable disease challenge that we have. And that translates to diabetes management and obesity management, especially when it comes to sugar control. So my goal here is just to highlight that the conversations are important, and we need to look at the carbohydrate conversation beyond just the individual level and consider that it affects the globe and it affects the planet. And my recommendation is that we should try to adopt healthier and more sustainable carbohydrate options going forward. Thank you very much. At the point, this is supposed to be a small conversation, but I think I am making it look like a lecture. But Dr. Alice, if you have a comment on what I've said, that is great. Over to you. Then we can go to the...
Thank you. Thank you very much for your discussion. Of course, I completely agree with you. So plant-based diet is the way to go. So in the program, by the time we are done, we also educate patients on the importance of plant-based diets. But that's a choice they have to make. We don't force them. But we have even a video that we watch that shows them how plant-based diets have helped people with their health, including cancers and things like that. So that is something we also do and encourage very, very much as we go. And of course, I also like what you said, we have to preserve people's culture. And this is why when you educate them, and I like the plate you showed, because consumer education is actually king, because most of the time people come to see the dietitian when they have a problem. Why can't we do more so that people know these things so they don't have to come to us with problems? So when you preserve culture, we don't change how they cook the food. Actually something like fat is not a problem. Eating fatty meat is not a problem. That's natural food. In fact, my PhD was about fat and carbohydrates, but we found that people who lived in the farms and ate farm-made food, mostly vegetable based, their bodies could make fatty acids that are healthy and prevented them from diabetes and other chronic conditions. But people who lived in the city and they ate the refined, and these are people who came from the village and then moved to the city, they had refined foods and they got into trouble with their health. So we have to encourage people to maintain the natural food, the culture, their food culture. And food cultures, if you go around the world, it's actually natural. It's only that when people move to the cities, then they start to have refined foods, the production of refined food starts. So that's the problem, But, consumers are very powerful. As long as we educate them, they will make the changes, Yeah.
I totally agree with you.
Mhm.
The health belief model, the rational thinking human being.
Mhm.
Great. Is there a question? I'm not too sure.
Mhm.
Is there a question or a comment?
Oh, let me check there.
I don't see a question.
Mhm. Yep.
Okay.
Mhm.
Yes. Yes, but I was seeking to learn your view on the Lancet's Planetary, the plant-based diet concept.
Mhm. Or my view, or everybody's view?
Yours.
Well, what do I say? I completely agree. So let me say, I was in a training in the summer, that's like June, and what we were doing with the students is to actually plan planetary planetary diets, and really just to plant-based diets, food pyramid, But I also want to say this is an area I'm just getting into, planetary health. So not quite really still confident talking too much about it, but this is what we are getting into. Yeah.
Okay. Yeah.
Mhm.
That's well noted. I
Yeah.
I do not see any other comments, but Dr. Mona, do you want to make a comment now?
Actually, I'm so impressed by both of the presentations. First of all, Dr. Alice, that's truly wonderful, this kind of awareness program and meticulous follow up with all your clients in a group. So this also encouraged them to adopt like a healthy lifestyle. So I truly congratulate you for this wonderful program, and it's highly needed nowadays when our lifestyle is messed up because of the life pace. It's rushing all the time. So people don't really have the time for mindful eating. This is very important. So I truly appreciate everything that you shared, Dr. Alice. Was even the resources and the references that you shared very much insightful. So, and regarding Percival, I truly like the perspective of seeing the bigger picture of how individual choices really affect the whole planet. Not just about food consumption and food waste, but also how the agriculture and practices in policy can also have an impact. So I just am, you know, thinking out loud with you about other dietary programs. You know, we have also intermittent fasting and one meal a day that some people adopt to overcome this kind of insulin resistance and having like um, just one meal, canceling the breakfast, so that this allows for the liver to perform this gluconeogenesis and release all the extra metabolism that's happening early in the morning. So there is a lot of details regarding nutrition, but overall, I mean, like a totally plant-based diet without any proteins is not good, and even ketogenic diet is also not for everyone. So a balanced diet is what we truly advocate for from a medical perspective. Because sometimes people, when they are totally on a plant-based diet, like vegetables or even fruits only, this could lead to some kind of culmination of autoimmune diseases because of the lectins present in some of the vegetables, especially. You know, there's some kind of different difficult metabolism of some of these components that can lead to autoimmune disease if the person is prone to this kind of diseases. So I'm just like contemplating on everything that has been shared, and thinking in the context even of Egypt and North Africa, because as you mentioned, Dr. Alice, it's very important to be culturally sensitive when we talk about anything related to food. It's part of the culture, after all, and people sometimes find it difficult to shift their mindset, especially nowadays with the holiday season. Gingerbread men and, you know, all these cookies around and Christmas time. So sometimes we feel like we are authoritative somehow, but then this is like, you know, the difficulty, the challenge, that how the mindset can be changed. So Dr. Alice, maybe you also can speak a little bit more about the challenges that you faced with the mindset of some of your clients who were resistant to this kind of, you know, quantitative program of carbohydrates intelligence.
So, Dr. Alice, you want to respond to that?
Yeah, I mean, there are challenges, but the good thing of having people in a group is there's always going to be others who motivate others. You know, there's so many theories that are displayed in the group. So you'll find that usually studies show that at least 40% will start straight away. They will take action. A few of them will think about it later, maybe another 30%, and then another 30% is going to do it much, much later, and only when they see the benefit. So in a group network, when people start to change, some people will not change at all, but when they start to see people changing and they start to see people giving comments, then is when they change. So yes, it's a challenge to change people's mindset. But what I found since I started doing group wellness activities in 2010, I find that they do much better. You know, it's easier to change than when you have individual. And then also when you do the group wellness program, you know, you're locked in for 12 weeks. For diabetes, it's 12 weeks, but for people without any chronic disease, it's only 6 weeks. So you lock people in for 6 weeks. So they have other sessions that are also beneficial. So they might not change the carbohydrates they take, but they change the portion size. They also start moving and exercising. they also pay attention to eating natural food rather than processed foods. And so whatever changes they make, it starts to help them. So to reduce the challenges, we have to, I mean, for me, what has worked is the group wellness program, locking people in 6 weeks or 12 weeks. When you see individual clients, they'll come, they don't like what you say, they are gone. You never get them again, so you won't help them again, you know. And that was something I experienced over the years. And I was like, you know, in fact, one reason I went to do my PhD, I had attempted my first PhD and then did the second PhD. It was health psychology, just understanding how people reason, because I couldn't understand, you're an intelligent person, you're diabetic, and then I'm telling you, this is what you need to do, but you do nothing. And they faithfully come for their appointments, but they've done nothing. And so it was very hard for me to, like, why can't you do something? I mean, I had to understand. And one thing that I understand that helps me is stages of change. So where are you in the stages of change? Are you pre-contemplating? Are you contemplating? Or have you gotten into action, you know, motivation and then action, you know, and then maintenance? So actually, when I used to see individual clients, when I understood that, I send you away. You know, you come 3 times, I know you're doing nothing. Then I tell you, you know what, you're not ready. When you're ready, you will come back. I'll be here. But now I cannot see you, you know. And so you find some people actually go and come back after a year or 2. But some people, they're like, oh my goodness, I can't do this alone. I have to do. But if you're going to work with me, then this is what you're going to do. If you don't do it, then this is a problem, you see. So, and I find that with the group wellness program, most people are already in the motivated group. But of course, there are some contemplators who have just come in because they've been told you have to come in by their doctor or something. But within the group now, they have to start moving. Some people say it like in week 8. Oh, I was just looking at everybody, and now is when I've started applying, and I'm actually doing very well. Like week 8, you know, we're almost finished. So the challenges are still there, but when we work as a group, discuss it from different regions, then we can understand how to overcome them. Yeah.
That's truly wonderful. And I really like that you studied this psychological aspect. Yeah, because craving for food is something that, you know, it also needs like delving deep into the psyche. Thank you so much, Dr.
Yeah, and you see, the other thing is how to educate. Maybe when I started teaching people, maybe I was so strict. I'm like, don't, you know, like the diet police. But it doesn't work. It does not work. You have got to tell them, you know, you can eat everything you want to eat, but the quantities. You know, I don't deny you a piece of cake as long as it's the carbohydrate you're going to eat in the meal. You know, so you can decide, okay, I'm going for a party, so I can have my vegetables, I can have my meat, but because I want to have dessert, I will have a tablespoon of rice, you know, then I can have a good piece of my cake. Nothing wrong with that. But if you're going to eat cake every day, then of course there's going to be a problem. So you don't deny. Over the years, I mean, I'm in 25 years practice. I don't deny them. Whatever they want to eat is fine. I never fight with them like, oh, you shouldn't eat this. No, you shouldn't eat this. You're like, no. What do you think? What do you think? What do you think? What do you think? What could you have done better? You know, what will you do better next time? And then they make the changes themselves, you know. Yeah. So it's also the approach. So when you're diet police, it doesn't work. So I won't stop you from eating. What is this I saw here? Waki? It's called waki.
Wachi.
Wachi, and I like it. I think it's made of rice and beans, eh?
Exactly.
So it's how much, darling? How much will you have this? And are you going to have some vegetables with it? You know, that's what you want you to do. Have some vegetables with it, you know. So it's always, hey, I have gari. I like my gari. It's how much, you know. Yeah.
Yeah. Thank you so much, Dr. Alice. That's really wonderful. And my question for Percival, out of curiosity, Percival, because my domain is in infectious diseases. And
Yeah.
I guess that you are also implementing some kind of nutritional programs to curb infectious diseases in a way, or to manage that. So let me know more about this approach, and what is your insight about which of those infectious diseases, gastrointestinal diseases, for example, or what really worked well with manipulation of the dietary habits or something like this?
Okay, so that's a wonderful question. My current research is into HIV and malaria largely. But currently we are doing we just started some proposals on gastrointestinal diseases, infections. But most of our work so far has been in malaria and HIV. And in this context, already there is that elevated energy needs. And so the idea for nutrition is to try to meet the fever-related, energy requirements and then still maintain healthy eating and meeting nutrient, managing the sugars, particularly for people with HIV/AIDS and other comorbidities. So those are the things that we typically do. And again, it's not too different from the conversations that we've had so far. When it comes to carbohydrate management, we are doing a lot of carbohydrate counting, because then we want to ensure that we are not exceeding the carbohydrate limits in a daily requirement. So that was actually a question I was going to ask Dr. Alice for her opinion on how they inculcate carbohydrate counting in the program. But I don't know if I'm just doing a quick time check. But if you can just squeeze that in, I'll be glad. Over.
Okay, actually, it's just once they are aware that a certain amount of carbohydrate gives you so much sugar, a certain amount of excuse me, a certain amount of food on your plate gives you so much sugar, then we actually don't go into the nitty-gritty because it's hard. That is the work for dietitians. We can count it easily. But so they will understand from their plate, because what we do, we actually, like you saw, I take the plate. Let me just show you again. So we take your food and we literally show you how much sugar that is that you took. So let me just share this slide again. So we have a collection, I'll just do from current slide so it doesn't take us back. You see, so we take food pictures and we are going to show you. This is, so you take 6 smoothies in a fruit, you're taking an equivalent of this, you get. And this is how much cake you take. Occasionally it's okay, but you can see that's like 75 grams of carbohydrate. So they understand. Plus, I told you we made a book. So this book, we made a book, and we're actually in the process of making a new book with different foods, and the ideas we get the ideas from this. So the books is going to help people see how much food, if you eat so much rice and so much bread, this is literally how much you're taking. And so they can check and see if I eat like rice and beans, and I eat a big plate, like everybody does, like how is that going to impact your blood sugar, And if you read the Unwin paper that I've done there, he did that study on like 9,000 people or, and yeah, it was quite impactful. So this, I find that it's impactful. So it's almost like they just fear to eat so much carbohydrates, which is not a good way. But we're actually, we are collecting a lot of data. And yeah, we'll have some analysis just to understand, what made you make these changes, and how did you feel about it? But usually at the beginning, when you come for next time you see we are doing an orientation program, just come and see. People will say, oh my goodness, there is no way, there is no way. In fact, I have a video from one of the participants from Ghana. Initially, it was like, there is no way, you're joking. It's not possible to eat like that, but it does. So it's just educating the patients. And you see, like I said, of course, there are challenges to educating them. But when you educate them, I have seen that there's a benefit. Once they understand it. And this is a discussion that happens over and over again. Day 1, they are quiet. Day 2, they ask questions about carbohydrates. And then in the second week, you can see now the changes. Is this good carbohydrate? Is this? And then you just tick and say, good trial, yeah. So it's education that really helps them. Yeah.
Yeah, that is wonderful. I'm happy to collaborate with you on that and replicate a similar thing here in a Ghanaian context and see if we can use Ghanaian foods in that same light and see
Yeah,
how
we
it
have Ghanaian foods, plantains and things like that. Yeah, we do. It would be nice because I would want that actually. Yeah.
Sure, we can always explore that.
Yeah.
So thank you so much, Dr. Alice Ojwang. I hope I got the name correct.
I wanted to say something about, sorry, 1 minute, from Dr. Mona's comments. You said something about you still need a protein to get your protein. Were you saying that? But I've actually, one of the things I also do is we deal with cancer patients. And right now we're following up some cancer patients and we put them on pure 100% plant protein. And if they know how to combine their foods, they are fine. Because the problem used to be what I used to be told growing up is B12 only comes from proteins, like animal protein, but that's not true. There's some foods that are high in that, and fermented foods is always going to give you B12. So you also encourage the clients to ferment their cabbage, ferment different vegetables, and they're fine. And we've done, there's a client of mine, we're following up patients with cancer with a doctor. And it's an official study, she just wanting to work with me to ensure that, okay, does this actually work? So here we have this patient, stage 1. This one is in the last stages. There's nothing to lose. The drugs are killing more than helping. So let's put them on a plan. And so we have actually helped a few patients, a good number, go into remission. So this is the time we're now putting together a protocol to go to ethics so that we can now do it as a part of a big study, but pure 100% plant. And you wouldn't believe the difference. It's unbelievable. The outcome is unbelievable. I'll send you a documentary that I've seen. In fact, let me try and find it. It's just doctors in the US and of course, putting patients, what the patients have gone through, like during treating cancer, what they've gone through. And then in the end, they are put on plant diet and, they make a remarkable recovery after almost everybody has given up. So 100% plant diet still works. It provides all the nutrients you need.
Yes, thank you, Dr. Alice. But you said something very important, fermented foods, because of B12. And also yeast can provide B12. So this is crucial because B12, it causes pernicious anemia and some kind of, anemia that's untreatable, except if you have the B12. So thank you so much, Dr. Alice. I would like also to hear perspectives from our new faces here, Elizabeth, Pauline, and Rosie. All, whoever have anything to share with us, please unmute yourself, and we truly appreciate that you are attending with us this meeting, and we need also to hear from you. Okay, so you can even type on the chat, and you have a feedback form. Kindly, it's like a QR code, so please scan that and share your feedback with us. This is very important for us to know what you have learned from both presentations today, and also to contact you after the meeting so that we can share with you our details of the next webinar. So back to you, Percival. If there is no questions, then maybe we can wrap up and close our meeting.
Wonderful. I thank you, Dr. Mona. I see that our participants today are very active. I see that we prefer not to speak, but to chat. Okay, so it's been a wonderful past few hours, and I want to thank Dr. Alice for your time and your presentation. Do you have any final words you want to share with us? Then we can pull down the curtain for today.
Okay, so just we need to be the change we want to see in the world. So if we are health professionals, what change do we want to see? And you need to live it and talk it. Yes.
Great. We need to live it and talk it. That is wonderful. That's wonderful. And from my end, we are grateful for your participation. Thank you for sharing your insight with us. And we are really excited that you've taught us a new perspective on carbohydrates. And you've taught us to be carbohydrate intelligent. And I'll definitely reach out to you after here.
That will be nice. I look forward to it.
But we need to make the intelligence go beyond just this meeting and see the rest of the world. Yes.
Yeah.
That's wonderful. And thank you, Dr. Mona, for putting this together. It's been an exciting and stimulating time. And I agree with you, Habib. He says, thank you so much, Dr. Alice, for this wonderful session. Highly insightful and stimulating. I totally agree with you. God bless you all for participating. Yusuf, Joe, Sammy, Rosie, Pauline, Paul. I mean, we didn't get to hear your voices, but we are glad you are here. Dr. Mona, see you all next month. But just a reminder, the new call for members of the MRN will be open in January. And feel free to, in fact, be sure to complete the survey, the evaluation form. It's a scanned copy. I'm going to reshare it in the chat. Just scan it and give us your feedback, and so that we can reach out to you and share with you an invitation for membership.